नमस्कार सर, कुलसेठ जी
नमस्कार।
नमस्कार।
नमस्कार। गुड इवनिंग सर। गुड इवनिंग
Good
टू ऑल ऑफ यू। डॉक्टर
good
राजीव
evening.
किशोर, गुड इवनिंग सर। डॉक्टर कौशल इज बिजी इन
क्या
कुछ पढ़ रहे हैं।
अतुल जी कहाँ से, विदेश से बोल रहे हो, यहाँ से बोल रहे हो?
नहीं, चंडीगढ़।
खबरें तरी तरी की आ रही है कि कभी कोई कहता है विदेश चले गए, दुबई
नहीं,
चले गए।
नहीं, दुबई नहीं।
अच्छा,
दुबई नहीं। एक्चुअली क्लिनिक बंद करनी पड़ी, तो क्लिनिक बंद करनी पड़ी, तो हमने कहा लो चंडीगढ़ हुआ है, वहाँ यहाँ बेटा है,
लगे
और
आप।
चांस की बात है ग्रैंड सन भी हुआ है अभी, तो
फिर तो लड्डू लेके आना, ऐसे मत आना भाई।
और फिर सबको कोरोना बांट दो। तो कोरोना में बंद किया, तो यहाँ आ गए चंडीगढ़। तो यहाँ पर बेटे अब 8th को उसकी 7th को बर्थडे, उसको मना के 8th को वापस बैक टू पेवेलियन, और 15th से काम चालू।
अच्छा,
फिर धुआंधार फिर से शुरू। एक्चुअली अप्रैल फर्स्ट वीक में हमें खुद कोरोना हो गया, कोविड हो गया, तो उसमें 7-8 दिन थोड़ा सा गड़बड़ रहा। उसके बाद नाउ एवरीथिंग इज क्लियर, तो इसीलिए फिर यहाँ आ गए। हमने कहा क्लिनिक बंद ही रखनी है, तो बेटे के साथ एंजॉय करें, ग्रैंडसन के साथ।
तो सर कोरोना पॉजिटिव थे तो फिर वहां चले गए बच्चों के साथ?
नहीं, पॉजिटिव नहीं, नेगेटिव होने के बाद। हमारा 8th ऑफ अप्रैल को पॉजिटिव थे, 8th को एंटीजन टेस्ट कराया, 9th को RT-PCR कराया, फिर 18 को 18th को नेगेटिव हो गए RT-PCR, और फिर एक बार और एंटीजन कराया, वो भी नेगेटिव। फिर उसके 7 दिन बाद फिर वापस यहाँ।
जी फिर ठीक था सर, क्योंकि ये तो
नहीं, वो तो पॉसिबल ही नहीं था, यहाँ फिर सबको फैलाते।
जी
चलिए।
Atul sir, good evening and many congratulations.
थैंक यू
Congratulations, sir.
थैंक यू।
Rajiv sir, should we start?
As you
Actually,
like, as
Dr.
you like.
Vineet Garg is busy. He will join after 10 minutes.
ठीक है।
So, with your permission, can I start the session, sir?
Sure.
So, on behalf of LK Laboratories Limited, India's fifth largest company, I welcome our all doctors who have just joined us for today's panel discussion. To help us to navigate with us, Dr. Rajiv Kishore, who is with us as a moderator for today's panel discussion. I also welcome Dr. V.N. Kausal sir, Dr. Atul Kushwaha sir. I also welcome Dr. Vipin Gupta, and in few minutes Dr. Vineet Garg will also join. So I hand over the session to Dr. Rajiv Kishore to start the panel discussion, sir.
Okay. Thank you so much. Thank you. Good evening, everybody. And
slides is visible.
Yeah, slides. You can have the first question. Yes.
Yeah.
Okay. So the first thing we're going to discuss today, and we have your opinion and frank opinion of everybody, that reduction of ASCVD risk with statins, specific reference to rosuvastatin. So what does the house think about? Are we able to reduce the ASCVD risk with statins or not? And if so, when you consider that you have a long list of statins, it is in India, not many are available. We have basically rosuvastatin, and then you have the atorvastatin and the pitavastatin. Basically, we have 3 of them. And so let's see. And what Dr. Kaushal sir, what is your idea? You really feel that ASCVD risk can be reduced with statins? And if so, which statin should be the best? Yes. What is your personal preference, and what you feel is the best statin to be used?
Well, definitely statins are one of the... Am I audible?
Yes.
Yeah.
Well, statins are one of the best drugs which can reduce the ASCVD risk. It is very clear. There is no doubt about it. Now, which statin reduces the risk? How much is something which is still not very clear. We in India had been using atorvastatin right from 10 milligram to 80 milligram per day, depending on the severity of the case. But as far as the reduction of ASCVD risk is concerned, majority of cases we had been using 20 or 40 milligram a day. And the results are very satisfactory. Rosuvastatin came very late into the armamentarium, say somewhere around more than a decade. We have started using it. And speaking on practical experience, because we as a clinician, we do not do all those trials and statistical analysis with the help of the pathological reports. So with the help of our clinical experience and clinical knowledge, I'll say both the drugs, atorvastatin and rosuvastatins, they work very nicely. But undoubtedly, if you want to reduce the LDL levels a little faster, in the first 8 to 12 weeks, rosuvastatin definitely scores over the atorvastatin. But after about 12 weeks of use, both the drugs are
Okay, Dr. Vipin Gupta, what is your impression? Let's have your opinion.
My opinion is the same with the Dr. Kaushal.
Okay.
It's better than atorvastatin in reducing the LDL cholesterol level in a bit early, in 6 to 8 weeks.
Your personal preference is to use rosuvastatin or use atorvastatin?
I'm using both.
Both.
Using both, but it causes faster reduction in LDL level.
Any specific condition where you use the other one? Maybe uh, in kidney failure, CKD or something you would like to change to atorvastatin? Any
In
preference like that?
in cardiovascular patient, most of the time we use in heart failure, initially ischemic heart failure, rosuvastatin, and in CKD patient we can use atorvastatin.
And you feel that definitely that ASCVD risk is definitely reduced with statins.
Yes.
You're quite sure. Dr. Atul, what do you say? What is your take on that? Reduction of ASCVD risk and which statin? Special reference to rosuvastatin.
Sir, unmute कर दीजिए.
Yeah. Absolutely. There is a no question mark over the ASCVD risk reduction with the use of statins because of the large hundreds of papers, thousands of papers are there. As far as the comparison between atorva and rosuvastatin, Dr. V.N. Kaushal has clearly highlighted that rosuvastatin, you can say it is a super statin. When it was introduced into the market, it was found that it was having a very fast action and very potent action as compared to the atorvastatin. So no doubt it is fast acting and it is having an edge in certain, most of the cases where the reduction of ASCVD is concerned or where there is a high inflammation in the body in the form of a high hsCRP, then naturally it scores over the atorvastatin. But as far as the atorvastatin is concerned, in cases with advanced renal failure, naturally, I think, in my opinion, the atorvastatin is slightly better as compared to rosuvastatin, but in most of the other cases, rosuvastatin is better drug as compared to atorvastatin. Over to Dr. Rajesh Kishore.
Okay. So ultimately, we have all decided that statins are a very good class of drugs and they are vital and they definitely reduce the ASCVD risk, and that is very important in any case of CAD or diabetes to have both primary and secondary prevention. In the case who has already had some episode, then of course we need secondary prevention, and wherever you doesn't have any, high risk cases should be given primary prevention. So in both aspects, your reduction of ASCVD risk is achieved with statins. Definitely, there is no group of drugs which can reduce the ASCVD risk as much as statins. And this is also the consensus that rosuvastatin is a more potent drug than atorvastatin. And if you want speed of action, then of course rosuvastatin is the drug of choice. And if someone doesn't tolerate rosuvastatin properly, you have more of myalgia or whatever, or you have CKD or some specific indications, then of course maybe you can go to atorvastatin. In any case, if one statin is not tolerated by the patient, it is always a dictum to either reduce the dose or change the statin. You can try another second statin. Some people don't tolerate both these statins, then of course you can go to pitavastatin, because some statin is better than no statin. Something is better than nothing always. So you don't give any statin, definitely better to give pitavastatin. Something is always there, because we have to think of some way to reduce the ASCVD risk. It is very important to get the good quality of life of the patient. That is vital. Okay, that is done. So let's go to the next discussion point. The next discussion point is which intensity statin one would like to give, the low, the moderate, the high, and for which type of patient. This is one part of the question. And the second part is that rosuvastatin moderate intensity would be 5 to 10, and high intensity would be 20 to 40. And for atorvastatin, this would be just double. For that, you have the atorvastatin would be 10 and 20, and high intensity would be 40 and 80. Because dose of atorvastatin is double of rosuvastatin. If you decide on atorvastatin, and if you are deciding on rosuvastatin, of course, then this is there. The same history is there. So yes, Dr. Kaushal sir, what is your take on that?
Definitely, the risk of the patient depends on many factors. There are different parameters related to the age also, like the recommendation is all the patients of 40 plus and who are diabetic should be given statin irrespective of their ASCVD risk. If a patient has got some comorbidities, then definitely he has to given the high statins or the moderate statin. The low dose statin of rosuvastatin is 5 milligram. 10 milligram will 10 milligram will probably, or 20 milligram will be moderate risk, and 40 milligram will be the high risk. So it all depends on what is the primary disease of the patient. Besides of the ASCVD score, one has to take in consideration about the other comorbidities also, and that is the reason. And his other habits also. If a patient, that all comes into the ASCVD scoring also, about the habits of the smoking, tobacco consumption. But ultimately, calculate the ASCVD score, look into the comorbidities, and accordingly, depending on the score, if it is more than 7.5, patient definitely has got a high risk and should always be given a high dose of statin. And high dose means, as you have already said, 20 to 40 milligram of rosuvastatin, and if you are inclined to use atorva, double the dose. We do not have any experience of the pitavastatin. I have started using after, I think 6 months back, we had a similar seminar. He spoke very high about the pitavastatin. So influenced by him. Because he's definitely a master of statins. I have started using the pitavastatin in few cases now. I think more than about a dozen cases are on pitavastatin now.
That's good. That's good. Okay. Dr. Vipin Gupta, what is your take on this high, moderate, low intensity, and what do you feel? Which type of patient should be given which?
Patient, I want to add one thing more. Level of LDL.
Okay.
If LDL level is very high, then we have to reduce the dose with high intensity of the statin.
Okay.
And the level of LDL is not very high, then we can use the low dose of statin. And what Dr. V.L. Kaushal said, that is right.
Then you feel the dose will be decided by the ASCVD risk level or the LDL level? Which one you feel is more important? Both are important.
Both are important.
Okay, you will consider both the ASCVD risk level and the LDL level. Before deciding
which level very high.
Okay. Because there are many theories in this. Some people just want to see the ASCVD risk level and then decide the dose. And some people want to give the level of, because today they say that level is not very important. The current consensus is there is an official recommendation, don't do lipid profile at all. Once you've done lipid profile, forget the lipid profile. Just see the risk and give the statin, because it has to be given lifelong in any case. So, but for a country like India, I think the level of LDL is also, has some bearing, and the patient has a feeling that he's chasing some target. Unless you start in a race and there's no finish line, then that race becomes pointless. You said when you finish, you don't know. Keep running. Whenever the judge says finish, you finish. Then current खत्म हो जाता है दौड़ने वाले का. फिनिश लाइन आपको पता है कि वहां तक दौड़ के पहुंचना है, तो जोर लगाएगा, लास्ट में और जोर लगाएगा, तो वो जोर लगाता है. So if patient can know the levels, तो थोड़ा लेवल से थोड़ा फर्क तो पड़ता है. मतलब you can have some incentive कि अभी मैं बहुत दूर, अभी तो जीतने में टाइम है, अभी ये है वो है, समथिंग. ASCVD रिस्क तो सरकारी चीज है, तो आप ही समझ सकते हैं. मरीज को इतना समझ में नहीं आता है ASCVD रिस्क को. अरे वो कहता है ये सब मेरी समझ में नहीं आता है. ये डॉक्टर कौशल है, मेक्स अ पॉइंट. यस सर.
There are both the sides of the coins.
Okay.
If you give target of LDL to the patient, he will follow it and he'll always come and trouble you. So it is better to give him a target of ASCVD. He will not understand it. We will have the control in our own hands to guide accordingly, that yes, and that is a better way also. The only thing is one has to develop a habit of calculating the ASCVD score on the first visit.
आजकल पेशेंट गूगल पढ़ के आता है, गूगल देख लेता है, अरे सर मेरा तो एलडीएल स्कोर इतना है खाली, ये तो ठीक है, गूगल बताता है, इसमें तो कोई बात नहीं है.
Then only one has to say that LDL is one part of the ASCVD score. We are covering 10 more aspects. You are considering only one aspect.
That's a good sign. Actually, now many tables are available. You can download any table, any risk calculator on your mobile.
It's simple.
The Framingham and that. But usually most of these calculators are meant for Caucasians, Europeans. So basic consensus now is that whatever risk you reach, you multiply by 1.5 for Indians. If you are an Indian and an Asian Indian, so whatever, if the table or that calculator is European based or American based, you multiply that by 1.5 to get the Indian, risk level. And that is more practical.
For all non-communicable diseases, be it hypertension, be it diabetes, be it coronary artery disease.
Because we are more at risk.
We score above the world in all those parameters.
Because for the same level of cholesterol, we are at least 3 times more at risk for developing any disease.
Yes.
So those calculators are okay, but we have to take it with we have to modify that as per our conditions. Dr. Atul, yes, what is your take?
I think everything has been covered with your discussion. I must say that it must be very clear, especially when you are going to start the statin therapy in a newly diagnosed patients of hyperlipidemia or high ASCVD risk. Then first thing is that the lipid profile is very important, and when the total cholesterol, when the LDL cholesterol is above 190 or 200, then it is a time to start with a moderate or high intensity statins like rosuvastatin 20 mg and so on. Even if the 10-year risk assessment is even less than 75 also, even then start with high level of high dose of statins, and then you can taper to medium intensity statins or low intensity statins according to the primary or prevention cohort. Now the second point is, in all established atherosclerotic cardiovascular disease, all the ASCVD patients who has already history of MI or ASCVD in the past, in that condition, definitely moderate or high intensity statins are indicated from day one, irrespective of the lipid profile levels. So these are both the things are clear. And especially thirdly, if a patient is having atherosclerotic cardiovascular disease already present, or they are controlled, and even then the patient is having some symptoms of unstable angina, or where there are chances of unstable plaque is there, in that case very high intensity statins are indicated. You can say 40 mg of rosuvastatin is to be given from day one to stabilize the vulnerable plaque. So in all these conditions, definitely moderate or high intensity statins are indicated, because they are not only controlling the lipid profile, they are having other pleomorphic action by which one can save the life of the patient. Over to Raju.
Okay. Another just one point to be clarified. So it is decided now that as per the ASCVD risk, or maybe the LDL level, or you can have both the parameters, and it's depending on your situation and the patient situation, you have to decide whether to give to high or low or moderate or whatever you have to give, and that you have to decide. And statin or moderate, high, we already decided the doses. One thing just to decide that if the patient is above 75 years of age, then what is your general trend? This same theory or the same dose or the same, whatever we have decided, is it valid for people below 75 and after 75, or you have to change something if the patient is more than 75? Yeah, Dr. Kaushal, sir, any modification you would like if patient is above 75?
One should not be so aggressive at the age of 75 plus.
Okay.
One has to reduce the dose of statin. That's what I usually do.
Okay. Dr. Vipin Gupta, what do you feel? Above 75, anything to be changed or no?
Low dose, because it causes myopathy. So in that case, low dose is much beneficial for the patient.
Okay. Dr. Atul, what do you feel? Above 75?
Again, we have to assess the risk profile in that particular patient. Suppose if a patient of 75 years is very high risk of ASCVD, and he is already on high intensity statin therapy, then it must be continued, even in spite of the age above 75. Second case, when a patient is not using statins before the 75 years of age, and suddenly there was a requirement of statins, then in that case, mild to moderate intensity statins are indicated. Thirdly, if a patient already using moderate intensity or high intensity statins, and he develops symptoms like myalgia, or you can say a slight dementia, then it is better to reduce the dose. So all the things are essential in a patient who is above 75 years of age.
Okay. So, but on the contrary, people who statins that develop less of dementia and less of Alzheimer. Sometimes it is said it is preventive against Alzheimer. And the problem is that as far as the data is concerned, a lot of work has been done on patients above 75. Even patient till 90, 95 years of age has been studied. And they found that giving high density statin even to at that age, they didn't provide, no harm was given, and the benefit still accrued. And statin should not be withdrawn in patients above 75 because of any risk. If they have CKD or they have progressive CKD, or do you feel that he's not tolerating it well, as Dr. Atul said, then that could be an indication for downgrading. You can come down one step. I mean, if you are high, you could come down to moderate. If you're moderate, you would come down to low. So that can be done. And so it is individualized. Nothing generalized statement cannot be given. It depends from patient to patient. But the data clearly says that even patients above 75 are going to benefit with statin treatment. So in days gone by, 10 years back, it was thought that above 75, there's no use of giving statins. But now they say now he's in the, I mean, that stage of life where they're not going to help much. But that's not the case, because trials have shown that people who are on statins, they do better. And their quality of life, even at that age, is better when they are on statins. So it is confirmed that depending on ASCVD risk or your LDL levels or your profiles, you have to give statins, the low, moderate or high, and age you have to may think of changing. If it doesn't tolerate properly, of course, then you can come down one step or change the statin. And if age above 75, again you have to individualize. There is no generalized statement. And if the patient is high risk or he's having recurrent episodes or he's having active CAD, then of course you have to continue with high risk. If you can tolerate, it is always that rider is always there. Maximally tolerated dose of statin. This is a very, I mean, catchy word, that maximum tolerated dose. Maximum tolerated dose, as much dose he can tolerate with comfort, without any discomfort. He says, आपने डॉक्टर साहब क्या दे दिया, इससे तो मैं बिल्कुल बेकार हो गया, मैं दिन भर लेटा ही रहता हूँ. So there is no point giving him that kind of drug where he gets dull and drowsy, myalgia, and he gets non-specific. There are many symptoms of statins are non-specific. Some people don't get myalgia, but they get tired. So you tell them, आपको दोपहर के बाद कैसा लगता है? You feel active. तो patient कहता है साहब 3-4 बजे बाद तो कुछ काम नहीं होता, मैं लगता है लेटा रहा हूँ. So पहले भी ऐसा था क्या? नहीं, अब हो गया जब से गोली खाई है. So if he really feels that after in the late evening he is absolutely dull and loss of energy and loss of, so that means that could be a statin effect. That is a very subtle effect of statin. Everyone doesn't get myalgia and muscle pains. So tiredness, exhaustion, this could be a very subtle manifestation of statin side effects. So you have to be very careful. You have to individualize the patient. Okay, let's go on to the next one now. And which statin combinations for which type of patients? Regarding, I mean, rosuvastatin, you can say which statin combination. You can combine Rosua with maybe ezetimibe, or maybe you want to combine this with the, fenofibrate or whatever. Is there any, what is your impression regarding, you want to just give statin alone, or in which kind of patient you would like to give, triglyceride lowering agent, or which one you would like to ezetimibe? Dr. Kaushal, sir, what you really
well, it really depends on the lipid profile report.
Okay.
One thing. Second, and after the initial experience of using the statins in that patient, if we are using high dose of statins in any patient and we are not getting the expected fall in the lipid levels, in the LDL levels, then probably we like to add ezetimibe to this. Now, as far as the fenofibrate is concerned, it has become a quite a confusing topic now, because the guidelines are that don't treat triglycerides till about 500 milligram. And I don't think that we in India have accepted it gladly. We always keep a rider on 500 milligram. A patient will not agree to it. It is maybe possible in those cases where patients do not have access to their reports. But here, the moment patient sees triglycerides of somewhere around 400 or 350, and the pathologist have highlighted the report, he opens the Google, as you said, Rajiv, and he is after the doctor said, give me some drug, give me some drug. So if a patient has got a cardiac history, if a patient is a high risk, if a patient has got a family history of dyslipidemia and family history of coronary artery disease and has got a high risk, then definitely I prefer reducing the triglyceride levels also with the help of the phenotype. Otherwise, if a patient is healthy, young, asymptomatic, has got the lipid profile report done because of something else or just as a routine, then I definitely ignore the triglyceride levels. I explained to him, ask him to do the physical exertion, ask him to do the diet restriction and try to reduce it with the non-medical, non-pharmacological methods. And that's what I do.
Thank you, sir. Dr. Vipin Gupta, what do you say regarding which combination of statin you prefer? A plain one with azitimib or maybe along with fenofibrate or whatever? And we are happy with Rosuva and that combination. You want to give some other statin combination? What do you feel?
I'm with the Dr. Kaushal.
Okay.
Rightly said.
Okay, done. Dr. Atul, what do you feel?
Yeah. Dr. Kaushal has clearly highlighted the details of combining different drugs like azitimib and others. And now it is very clear that as Dr. Kaushal has said, when we are increasing or doubling the dose of the statins, the effect is not doubled, but it is only for 6 to 8% more reduction in the LDL, or you can say the total lipid profile. That's why if even the maximally tolerated dose of statins, we are not able to achieve the target, then it is better to add azitimib, because that is a very addictive, and clinically I have found a very good result with the use of azitimib. Anyway, second thing is the addition of triglycerides. Most of the patients having dyslipidemia with high cholesterol, high TG, and TG, if they are not much elevated, like they are in the range of 200, 300, I usually advise them to undergo blood glucose levels. Because most of the time in diabetic patients, what happened that when you control the blood glucose, the TG levels automatically came down to the normal. So in that condition, it is not a good thing to add the triglyceride lowering drugs like fenofibrate from day one. So just reassure, reconfirm by the blood glucose level and ask the patient to continue physical activity, more physical activity, low fat in the diet, so that TG levels can be controlled. And after about 6 to 12 weeks, if they are not controlled, it is better to add fenofibrate in that case. Now, beside this, few companies has introduced vitamin D also with statins. And I don't think that there is any favorable effect of addition of vitamin D with the statins. As far as the addition of, you can say, aspirin, clopidogrel, etc., they are done here with the statins. So they are useful in cardiovascular disease, high-risk cases of CVD, then they are definitely indicated. So these are my opinion of combination of different drugs. As far as the PCSK9 inhibitors are concerned, I have never used. Any idea of Dr. Rajiv Kishore? Have you used PCSK9 inhibitors? No.
I'd used in one case actually, but after 6 months he lost to follow, because I think it is
very costly,
cumbersome for him.
Yeah.
From Delhi.
Otherwise, in cases of the hypercholesterolemia, familial hypercholesterolemia, I think that can be used. Otherwise, most of the cases are controlled very well with diet as well as the statin, high dose of statin therapy, or as the addition of the azitimib. Yeah.
So, considering the consensus, now it is decided that the combinations are there. Normally, you're giving rosuvastatin. If it is not able to tolerate, then you can change to atorvastatin. then now we know that triglyceride is not a primary target, although in days to come, evidence is mounting up. Maybe in Asian Indians and Indians especially, triglyceride may become a secondary target, but it is not yet. But non-LDL cholesterol, once it becomes a target, the non-LDL cholesterol includes the triglyceride part also. So maybe non-HDL cholesterol may become a target, and triglycerides, we all know that when even triglyceride is mild to moderately raised, even if triglyceride is in the range of 200 or 250, then LDL changes from large buoyant to small dense. So the quality of LDL changes if triglyceride is even moderately elevated. So indirectly it affects the, I mean, everything, when anything affecting the LDL is basic actually. So there's no benefit of maintaining high triglyceride levels, but present consensus is unless it's more than 500, we don't give primary target, don't consider it as a primary target. We're not giving drugs unless it is above 400 or 500, because that time there is risk of pancreatitis. Then only we are giving, but evidence is mounting up gradually that triglyceride should be considered as a additional risk factor, especially in Asia and Indians and in diabetics. Because as Dr. Atul said, maybe once you control the sugars and maybe you've eliminated the hypothyroid part and maybe you have given proper dose of thyroid, because hypothyroid is also one reason for getting high TG. So if you have controlled, checked the thyroid and you have checked the sugar and still triglyceride continue to remain on a higher state, then of course I think that could be a target in times to come. For today, maybe one alternative is to give low dose fenofibrate. There are many preparations available with 67 or something fenofibrate. So giving low dose of fenofibrate may be one option where there is no side effect of fenofibrate, and you can give the low dose of fenofibrate along with statin. There are combinations available with, I mean, 150 of fenofibrate and statin and 67 of fenofibrate with statin. So those kind of combinations can be tried. As far as ezetimibe is there, ezetimibe is a very good drug, and as Dr. Atul has said, that doubling the dose only reduces cholesterol more by 6 to 8%. But if you add ezetimibe, you have a multifold decrease in the cholesterol. The problem was it didn't have much proof. First, it was thought that ezetimibe reduces the LDL, but you don't get mortality benefits. But now many trials are there. The SANDS trial is there. Many trials have come up now, and they have shown that the reduction of LDL is important. It doesn't matter how you lower it. Like the blood pressure, first it was, although it is still important by which drug you're lowering it, but more important is lowering of BP. You should get the BP in limit. That's the first thing. So here also getting the cholesterol under control is the most important thing. And even if you lower it with ezetimibe, you are getting the mortality benefits. So there are trials available to show that that is helpful, because ezetimibe was an old drug. It is not a new drug. But initially it was gone into disrepute because they said you don't get any pleiotropic benefits and you don't get any long-term cardiovascular benefits. But that is now not the case, and trials show that you do get benefit. So combining ezetimibe is a very good option, especially in cases of not tolerating high doses of statins. And those who are not tolerating the high intensity statin, and many people, of course, they can tolerate mild to moderate, but high intensity many people don't tolerate. So the good thing is you can combine just 10 milligram of rosuvastatin along with ezetimibe, and that would give you reduction just like 40 milligram of rosuvastatin. So you get the benefit without the side effect of that. And Dr. Kaushal sir?
What is your opinion about using saroglitazar in diabetic dyslipidemias? Addition of saroglitazar.
Oh, that's another very tricky question actually. The problem is with the Indian dyslipidemia and the diabetic dyslipidemia, saroglitazar is a wonderful drug because it's targeting the PPARA
That's
gamma.
what I wanted.
Yeah, and that is a wonderful drug, but it is actually not under our discussion today because it's not a statin. It is a glitazone. So saroglitazar is a wonderful drug. You can have two birds with one stone. You can control the sugar also and control the cholesterol.
It works nicely in diabetic dyslipidemia along
very
with
nice.
statin.
And plus you can control the VLDL and the triglyceride, which are hardly targeted because statins also don't tolerate that. They don't target the LDL and the VLDL and the TG. While saroglitazar has mild to moderate effect on LDL, but very good effect on the TG and VLDL. So when you are giving saroglitazar, you have in diabetic dyslipidemics, I think saroglitazar could be a welcome addition.
Very good, sir.
It could be that statin combined with saroglitazar. So you are giving saroglitazar that will cover the diabetic and the VLDL part and the TG part, and statin will take care of the LDL part. And then you don't have to bother about the ezetimibe, and don't have to bother about getting that very high. Maybe even moderate intensity statin will do the work for LDL. because saroglitazar also gives about 10% reduction in LDL. So you have some mild reduction also in LDL, but a good major reduction in, I mean, we have
TG.
patients on, I had patients of 1600 triglyceride. They came down to 300 and after 4 or 5 months of saroglitazar. So without fenofibrate. So I've totally obviated the need for, fenofibrate. And this is very good, nicely tolerated, no weight gain, nothing, and no, it's a very safe drug, very nice drug. And recently it has been about to be approved for, it's the Indian DG, India has approved for fatty liver, NFLD, which is really the case in so many Indian patients. I feel all the diabetics are cases of NFLD. Even healthy, otherwise healthy people in India, a lot of them, if you do a random ultrasound, everyone will come out to be fatty liver, fatty liver. What is the exact significance? We don't know. Maybe because of a lifestyle, maybe it's a genetic, we have no idea at all. So maybe a
Causes
childhood.
some weight loss also.
So some weight loss also. So either way, it's a very good drug. Saroglitazar is a wonderful drug. And
Also in diabetes.
yeah, especially in diabetics. If you get a combination of saroglitazar plus statin, that would be wonderful. That would be just the ideal case. Instead of combining that with statin or something else, a combination of saroglitazar plus statin could be wonderful. Okay, so let's go on to the next discussion point. There is a dictum, and some people really say that every diabetic should be given statin after 40 years of age, regardless of the baseline LDL. So, a lot of experience is there with rosuvastatin, and what do you feel with the? Is this the case? All of you are really giving it like that, and is this the case? And everyone should be given every diabetic after 40. And in those cases, what is the experience with the other statins, and special reference to rosuvastatin? Dr. Kaushal, sir, yes.
Well, we live in an era of the evidence-based medicines. And the evidence says, and the recommendation says that every patient who is diabetic and 40 plus should be given a statin. If his lipid profile is normal, he should be given a low dose of statin, whether you give atorvastatin 10 milligram or you give rosuvastatin 5 milligram. But if the lipid profile is abnormal, then according to the abnormality, the dose has to be increased. But I agree that every 40 plus diabetic should be on steroids, because steroids have got many pleiotropic actions, as we all know. So in a long run, it is much beneficial to the diabetic. Secondly, diabetics have got a very high tendency. Almost they are more prone, almost double, 2 times prone for the cardiovascular complications and the diseases. So statin works as a prevention also. So I agree that every 40 plus should have a statin.
And that also, if possible, rosuvastatin, the potent one. Okay. Dr. Vipin Gupta, what do you say regarding?
Yeah,
in most
for
of the
that I
patients,
will agree. For that I will prefer rosuva.
Okay.
in the most of the patient we are using statins.
Okay.
Having most of the patient having cardiovascular disease also, hypertension, etc. Then we are using statins in all diabetic patients, in most of the diabetic patients.
So suppose he doesn't have anything, no other risk factor, only diabetes, and age more than 40, you would like to give?
No. If lipid profile is normal, then we can wait. But if lipid profile is abnormal, then we add in most of the cases.
Okay. Dr. Atul, what do you feel? What do you say to this?
Yeah, there is a clear-cut guidelines all over the world that if a patient of type 1 diabetes with more than 20 years of diabetes, then do lipid profile. If it is abnormal, give statins mild to moderate grade. Secondly, if a patient is above 40 years of age, then it is recommended irrespective of the lipid levels. Thirdly, if a patient above 40 years of age, diabetic patient, do ASCVD risk profile. If 10 years risk of ASCVD is more than 7.5, give moderate or high intensity statins, especially rosuvastatins. So these are the clear-cut guidelines. And usually we are not giving high intensity, but we are assessing the other risk. We are assessing the risk of ASCVD in every every diabetic patient. If risk is higher, then we are giving moderate intensity statins. If the risk is low, age is above 40, we are giving low dose statins. It is clear. But if the age is less than 40, and if the patient, in spite of that, they are having bad family history of ischemic heart disease, or they are having past evidence of any ASCVD, then again, we, in spite of below 40 years of age, in diabetic patients, we are using moderate to high intensity statin.
And which statin you prefer? Rosuvastatin?
Rosuvastatin is better because dose to dose, you can say about 20 mg of rosuvastatin is equivalent to 40 mg of atorvastatin. So in that condition, 20 mg of rosuvastatin I usually give. As far as the blood glucose control is there, after Jupiter trial, there was a question mark that probably rosuvastatin is increasing the blood glucose levels. But clinically, it is not clear, and it is found, it is also noticed with the atorvastatin trial that there was slight increase in the slight derangement in the blood glucose. So you can adjust the dose of the blood glucose accordingly and give the benefit to the patient by using the rosuvastatin in that particular patient.
Okay, so we have all decided that that if the patient above 40 years is a diabetic, then hopefully he should be given some kind of statin. And Dr. Vipin Gupta said that unless if he has no risk factor, then we like to wait and watch. But today the evidence says that most of these diabetic patients, say more than 70% have got some kind of CAD, and 50% have got occult CAD, because it's very difficult to say whether to eliminate CAD is really very difficult. There are so many tests involved, and no test is really there which can prophylactically say that this person is going to get CAD later on. Because all those tests, even calcium scoring, carotid intermedia thickness, even echos and stress echos, and I mean everything is a failure, including angiography is a failure, because angiography will tell you the anatomical blocks, but very it is not going to tell you the physiological blocks. You can do a thallium scanning, but none can really correlate what exactly is going to happen after 10 years. So many of these patients have got occult CAD, and diabetics have got, a lot of patients got occult CAD. And today it is known that it is not the dose of statin which is so important, it's the duration of statin taking is more important. So at 40 years, if every diabetic is put on a statin, then suppose he gets a MI at 55 or 60 years. So he will have a history of 20 statin years behind him. So having those 20s, maybe he's getting the minimum dose, maybe he's getting 5 or 10 milligram of rosuvastatin, doesn't matter. But 20 years of having 5 or 10 milligram of rosuvastatin is going to make his plaques very stable. And probably he will not have that MI which he is going to have. Or if he has a MI, it will be very mild. So number of statin years is very important, like cigarette smoking. You know, it is not so much dependent on how much you smoke. You might be smoking 1 pack or 2 packs a day. But if you are, how long you are going to be smoking, you're smoking for 20 years, 30 years, that's going to create the damage. And even if you're smoking 1 pack or 2 packs and you've only spoken for 6 months, maybe you don't get that much damage. So same thing here. The number of statin years is very important for the pleiotropic benefits. So the longer you carry on with statins, the more stable your system gets. Maybe you can get a plaque regression, maybe you can get a plaque stabilization. So a lot of things happen. So today the trend is that if he is a diabetic, every diabetic is a cardiac equivalent. You all know that diabetes is a cardiac equivalent. Having diabetes is like having had a heart attack. So every diabetic should be given the benefit of statin. If you are not so confident how much you want to give the lowest dose. Give 5 milligram of rosuvastatin. Even that, given over a long period of time, is going to give him a good legacy. You have a good cardiovascular legacy, and his cardiovascular system will be much more stable to deal with any of the problems and emergencies that may arise at 55 or 60 years. But suppose he has not been given a statin, and when he gets a MI at 60 years, then you start the statin, then of course the benefit of statin will not be there. Even if you give a high dose, you will have limited benefit. See, hypercholesterolemia, ASCVD is a systemic disease. Basically, because the coronary arteries in Indians are small, not so tortuous, and less diameter, so this is manifested earlier. But it is a systemic disease. So all the arteries are getting atherosclerosis, even the cerebral arteries, the penile arteries, the lower limb arteries, everything is getting. So it's a systemic disease. Maybe you get peripheral vascular disease, maybe you get cerebral vascular disease later on. It is known that erectile dysfunction occurs very early in diabetic patients. And erectile dysfunction, because the penile artery is very small, and that gets blocked very early. So any diabetic getting erectile dysfunction, it's a very clear indication that he is going into atherosclerosis and needs high dose of statins. So that's why today it is advisable that if he's a diabetic, diabetes is a high risk disease already, and he should be put on some kind of statin if he can tolerate it, maybe low dose, maybe medium dose. Everyone agrees high dose only if really indicated, high dose only if high intensity, if the ASCVD risk is high and he has other comorbid conditions which warrant high dose. Otherwise, low to medium dose can definitely be given to every diabetic above 40 years. That is the consensus of what the medical evidence says as per evidence-based medicine. A lot of trials were done on patients who were given at 40 years and patients who were not given at 40 years. So patients who were given at 40 years, they did much better when they reached 60 years. Their long-term mortalities and morbidities were much less. So it is always a beneficial, I feel, in diabetics to give statins. Maybe you can give it very low dose, 5 milligram, because but long-term is going to benefit. That's the real thing. And rosuvastatin, of course, everyone says is more potent, so that is a better thing. But it really doesn't make much of a difference. When you're giving low dose, you can give 5 rosuva or 10 atorva, that would be equivalent. Of course, because once you're giving long time, rosuva is fast acting. As Dr. Kaushal said, after 6 months or so, maybe everything is the same. Once you have reached standard state, like your H2 receptor blockers, proton pump inhibitors, there are so many long lists. But initially, someone acts faster, someone acts slower, but after 1 month or 15 days, all are the same, you know. फिर तो सब गधे घोड़े एक ही भाव बिकते हैं, फिर तो कोई फर्क नहीं पड़ता. Okay, so let's go on to the next question. Statins for primary and secondary prevention, evidence and experience with rosuvastatin. So there are two things. One is the primary prevention. A person who doesn't have any evidence, any objective, I mean subjective or on investigation, there's no clear evidence of CVD, and but he's a high risk case. Maybe he's got family history, he's got other problems. Then would you like to give that? That is the primary prevention. And once you get some episode of maybe he gets MI, gets angina, you can demonstrate some blockade. You can see he's got evidence of CAD. Then of course, and he has got high ASCVD risk. Then of course that is secondary prevention. So what do you feel regarding statins? Are they good for primary prevention? Are they good for secondary prevention? And what do you feel regarding long-term use? Dr. Kaushal, sir.
We never had any doubt about the secondary prevention of the statins. When we were using atorvastatin and now rosuvastatin, there was never any doubt, and there is no doubt about the secondary role of statins in the secondary prevention. Now, if I talk about more than a decade back, there was some clouds over the primary prevention of the statins. We were skeptical whether the use of statins will do some good to those patients or not. But now the things are becoming clear after so many trials that if a patient has got a strong family history of coronary artery disease, if a person has got a family history of a young coronary artery disease, the statins do a lot of good for the primary prevention also. And as Rajiv, we have already said, it is not the dose of a statin, it is the years of a statin. If a patient has been put on statins at a very young age, looking into his family history or looking to his ASCVD score or looking to his hypertension status, then he has taken it for a long period of years, then probably the severity of the coronary artery disease or the complications of the coronary artery disease as and when he gets will be much less. So I will definitely high risk for the coronary artery. Well, there is no doubt about the secondary prevention. We have been talking about all those aspects, that where it should be used as a secondary prevention and what doses should be used.
Okay, Dr. Vipin.
That's what my take is.
Yeah.
Dr. Kaushal rightly said, sir, in the primary prevention, in the family history and in younger patient, the primary prevention is important, and statin should be given. And in the secondary prevention also, you have discussed a lot in this regard. I'm with the Dr. Kaushal.
Okay. Dr. Atul, what do you say? Your take.
Dr. Kaushal has clearly highlighted each and every points about the primary and as well as the secondary prevention. Here, I want to add something, that if a patient is there, young female patient having multiple risk factors, then if she is interested for child bearing, then it is to be avoided. Otherwise, in most of the patients where there is a family history of heart disease or family history of peripheral artery disease or cardiovascular disease and different types of atherosclerotic cardiovascular disease, definitely there must be primary prevention is very important by statins in all these cases. Otherwise, if there is a contraindication, otherwise, in every case, they are indicated, strongly indicated. Statins are strongly indicated.
Okay, so the consensus opinion is there that for high risk cases, primary prevention is definitely a must. It can be given, it is successful. And as we have talked, Dr. Kaushal highlighted that if you give for a long time and giving even a low dose statin for a long period, definitely is going to have benefits in the long run. And secondary prevention, there is no doubt at all. If you have got CAD, active CAD, any episode of CAD, of course, you have to be given statin. There is no question, no doubt. And there's no absolutely no discussion about that. That for secondary, it is definitely in. And for primary also, there is a high possibility, especially in the high risk cases, that you should use it because you are going to get benefits in the long run. And if statins, as you know, now we are talking of COVID era. So in COVID times, today a lot of discussion is there because a lot of patients who are on statins, they are getting COVID. And there is some discussion whether statins could be active treatment for COVID. So a lot of, theories and papers are presented now. And inside that short-term statins may not help you so much. But if someone is on statins from before, he is getting less severe COVID. Because they say that statins deplete the cholesterol in the cell wall of the cell wall has got cholesterol. So it depletes the cell wall cholesterol. So less of virus get attached to the lipid in the cell wall. So if you've got less of lipid, so less of virus can attach itself, So and when you take statin, the cholesterol compound is changed in the cell wall, has a different compound. So that compound 25OH or 25SC, there are some different compound is there, that cholesterol is in a different form. So that form does not encourage the binding of the virus particle. So you can get some benefit, and then intracellular lipid is also less. So there also the virus goes through the lipid. The virus also has got a lipid actually envelope. So it is beneficial either way. If you have a low, cholesterol in the cell membrane, and you have basically cholesterol decreases the cholesterol in the arterial wall, but it also depletes the cholesterol in the cell wall. All the cells of the body, it depletes the cholesterol in the membrane. So that, and plus these inflammatory markers, the IL-6 and the TNFs, and many of them are based on lipid. So if you have less of lipid in the body, naturally less inflammatory markers will be formed. So maybe there is a case, and they have found in some big trials, they are under publication, that people who were on statin, they didn't get such a severe form of COVID, and they fared much better if they were on statins. So that is a fringe benefit. Another pleiotropic benefit of statin, that if you are on long-term statin, maybe you get these, because depletion of the cell membrane with statin will take a long time. So unless you are on statin from before, you're not going to get that benefit. So still, in the current state of knowledge, even high-dose statin as a treatment for COVID is still not recommended. That may take time unless you get the proper trials for that. Maybe like in acute MI, we give a high-dose statin, for 3 months or 6 months. Maybe it will come out later on that high dose of statin with COVID is beneficial. We don't know, not yet. Evidence-based medicine. But it is really confirmed that there is no contraindication for statin. If you're on statin, you get COVID, you can continue statin in these COVID times, and you are definitely a better risk factor if you're on statin than if you're not on statin. So that is another benefit people on statins are going to get nowadays. So I think we have covered all the points. We have done a lot of discussion, a lot of water is flown.
Dr. Rajiv, one query. If a patient is using statin plus aspirin in low dose, then there will be further benefit because statin is taking care of the anti-inflammatory points and decreasing the lipids during COVID era, and the aspirin is causing the decrease in hypercoagulable states. So I think there must be further benefit of that.
Actually, the aspirin does not affect the coagulability factors of COVID, because there you need factor 10A. Anti-10A is must, because this will only affect the platelet aggregation. So for the ASCVD, aspirin is okay, but for the for the COVID coagulability, we need some anti-factor 10. That you have to need some of those Clexanes or enoxapyrines, or maybe the rivaroxaban or apixaban or whatever. You have to give those category of drugs. NOACs, they will the right drugs to give, because Dispirin is not benefiting in this hypercoagulable state of COVID specifically. So you can continue with this 25, because someone who is taking aspirin for whatever indication, he still needs that, because this already is a hypercoagulable state. We are getting there are reports all over from who are getting cerebral thrombosis, people getting renal artery thrombosis, getting mesenteric artery thrombosis, presenting with acute gangrene of the bowel. So a lot of cases are in Bombay. There are reports of getting people getting ischemic necrosis of the bowel, and these clots from the lung basically start from the lung and the pulmonary vasculature, and they spread all over the body. So there's definite case for giving these anti-factor 10A anticoagulant drugs at least for 2 or 3 months in cases who have had frank COVID, and especially who have a patch in their lungs. Doesn't matter. It's many people say that I've only got 2/25. It's very mild. It is nothing. But there's nothing. There's nothing called mild like heart failure. There's nothing like mild heart failure. Heart failure is always heart failure. So I've got a little bit of diabetes. There's no little bit of diabetes. Diabetes is diabetes. Either you're diabetic or non-diabetic. So many people are very happy. I've got little bit diabetes. It has just started. No problem. So that is not the case. If you have got diabetes, it has to be treated, and you are a high risk. You go in the diabetic category. Either you are a pre-diabetic, that's a different. You're in a different compartment. If once you're diabetic, you're diabetic. So something like that. If you have a patch in the lungs and you have the inflammatory markers have become like that, the lungs have got a patch, because you're not carrying out CT every day. Because the day you do the CT, maybe it is 2/25. After 1 week, it becomes 7/25, 10/25. Because no one does the CT again and again. At whatever stage you do it only once. That's why I try to delay the CT as far as possible. 8th or 10th day would be the nice time to do the CT. But unless you have pressing indications, some people have need oxygen support, some people have a poor GC, some people have other problems, they develop high fever, then of course, the people panic actually, that is the main problem. I have patients coming on after 4th or 5th day of fever and they've already done CT 3 times. पहले दिन तो मेरे बेटे ने कहा आज करा लो, कल मेरे दामाद ने कह दिया, परसों मेरे एक डॉक्टर है मुंबई में, उन्होंने कह दिया. तो 3 बार सीटी हो चुका मेरे पास आने के पहले, एंड तीनों हो गए 5 दिन के अंदर ही अंदर. तो एक्चुअल डैमेज इज नॉट विजिबल. और वो सीटी तो आप जल्दी करा लें तो यू गेट अ फॉल्स सेंस ऑफ सिक्योरिटी कि मेरा सीटी तो अच्छा है साहब, कुछ नहीं है साहब, मैं तो ठीक हूँ. एंड लेटर ऑन यू गेट दैट पैच इन द लंग्स. So actually this clotting is happening all over, maybe wherever in the body. But the lung is the most, mirror of the body which you can see on the CT. Other systems is not so easy to get the, finding. Even in the lung today, in the pulmonary vasculature, unless you do a pulmonary CT angio, the microthrombi are still being unable to be detected. In UK today, now it is mandatory if you get a patch on CT, you are advised to do a pulmonary CT. Because they say pulmonary angiography is only going to really decide about the microthrombi. Because many patients, even after 1 month, 2 months of COVID, they are still getting dyspneic. They are still not able to maintain their oxygen properly. They need occasional oxygen. So they are the cases who got microthrombi inside the pulmonary vasculature. You can only get on, pulmonary CT. And it's difficult to get by anything else. And these inflammatory markers, they are helpful, but you all know today there is a lot of disparity. They may rise, the CT may, the IL-6 may rise, may not rise, the CRP may rise, may not rise. If they are concordant with the diagnosis, it's okay, but they are not compulsory. Sometimes you get people with very high CRP, IL-6, they're doing very well. No oxygen, nothing. And many people with, hardly any rise of CRP, IL-6, they are on oxygen support and they are on ventilator. So there is, correlation is not very strong today. Everything is possible in COVID era. Okay, so let's back to our host. Where is our host? I can't see him.
Amit Sharma.
Amit ji, आइए कहाँ मैदान में आ जाइए.
Yes sir, my voice is audible.
Very nice.
You are also visible.
Thank you sir. That was a very nice discussion sir. Okay. I take this opportunity to thank Dr. Rajiv Kusur, who is moderating the panel discussion, experience of Galaxy with rosuvastatin. I also thanks Dr. V.M. Kausal sir, Dr. Vipin sir, Dr. Atul sir, for sharing their experience of Galaxy in your clinical practice. I also thank to all doctors who have just joined us for today's panel discussion. We salute our all doctors and our paramedics who keep us safe in this challenging time. So we salute all the doctors, and at Alkem we are always ready to serve you with providing our products available, Jupiros, Glubilda and Alkem. And sir, I want to introduce one more initiative of Alkem. The ATKF has launched a Connect to Clinic platform. This is a virtual platform. You can see your patient on online. So there are very good features that the payment schedule is within 24 hours straight in your account, and safety is very good. So I request you to please use this C2C and recommend your colleagues also, sir.
Thank you.
Okay, thank you.
Thank you, sir.
Good
Thank
night.
you very
Good
much.
night to all of you. Good night, Dr. Kaushal, and good night,
Good night,
Dr.
sir.
Ayush.
Good night,
Okay,
sir.
Dr. Vipin.
God night.
Good night. Good
Good
night.
night, sir.
Okay.
Okay, okay. Thank you. Thank you. Bye, everybody. Have a nice day. Okay.